Okay, let's dive deep into a really specific and important topic today. We've got this comprehensive set of revision notes on multiple system atrophy MSA.
That's right.
And our mission really is to unpack them, pull out the absolute highest yield info and, make it stick for your revision.
Mm,
Think of it as cutting through all the complexity to find those essential nuggets you really need to know.
exactly. We're going to work through these notes section by section, looking at everything from the core definition right through to the potential complications later on.
Right.
Our goal is basically to guide you through the key points definition, etiology, risk factors, pathophysiology, differentials, epidemiology, clinical presentation, investigations, management, prognosis, and complications, highlighting what's most important for recall.
Yeah, and this isn't just about reading the notes aloud, is it? It's more having a conversation that helps you understand the crucial bits of MSA, why they matter, how they fit together.
Let's get into it then. It's a challenging condition, no doubt.
Definitely. Where should we start? Definition.
Let's begin right there with the definition. So, multiple system atrophy, or MSA, it's a rare neurodegenerative disorder.
Okay.
Essentially, it involves a progressive loss of nerve cells, and crucially, it affects multiple areas within the brain and the spinal cord.
Right, and because it hits these different spots, it leads to, well, a combination of problems, doesn't it? The notes seem to really emphasize three key clinical areas: Parkinsonism,
Yep.
autonomic dysfunction, and cerebellar ataxia.
Exactly. So you often see issues with movement, kind of Parkinson's, plus problems with automatic body functions, blood pressure, bladder, that sort of thing, and coordination issues, all cropping up together.
Okay, makes sense.
And depending on which set of symptoms is sort of leading the charge, the notes describe two main subtypes. There's MSA-P, where Parkinsonism features are dominant,
P for Parkinsonism,
right? And MSA-C, where cerebellar ataxia is the primary issue.
C for cerebellar. Got it.
And the notes also mention Scheidrader syndrome. That's an older term that kind of falls under the MSA umbrella now.
Okay, so for revision, maybe picture MSA hitting those three main systems: movement, Parkinsonism, the body's autopilot, autonomic, and coordination, cerebellar ataxia.
That's a good way to think about it.
And the P or C subtype just tells you which system is shouting the loudest initially. That simple structure seems pretty key to grasp.
It really is. Now, when we look at etiology, the notes are quite upfront. The exact cause isn't fully known.
Right, often the case with these conditions.
It is. But genetic and environmental factors are thought to be involved somehow.
But there is a key pathological thing mentioned, right?
Yep.
Something about protein buildup.
Yes, exactly. It involves the buildup of abnormal protein aggregates in the brain.
Mm-hmm.
And the specific protein they highlight is α-synuclein.
Ah, α-synuclein. That rings a bell from other conditions too, like Parkinson's.
It does, yes.
Yeah.
But in MSA, this abnormal alpha-synuclein accumulates within these specific structures called glial cytoplasmic inclusions, or GCIs.
GCIs.
Okay.
And these are found inside glial cells. Those are the brain support cells. The notes actually identify alpha-synuclein as the main component of these GCIs.
So they're not just in the neurons, but in the support cells too.
Correct. And there's also mention of another protein, P25-alpha, that seems to stimulate this alpha-synuclein buildup.
Okay, so alpha-synuclein is the bad actor protein, and the GCIs are like the little bundles of trouble it forms inside the glial cells.
Pretty much.
And it's these GCIs that are linked to the progressive nerve cell loss in those different brain areas we mentioned earlier.
That's the connection. Alpha-synuclein leads to GCIs, which leads to nerve loss, which ultimately causes the symptoms.
Maybe a little memory hook. Like alpha-synuclein is the alpha problem protein building clumps, GCIs, in glial cells. AGC for etiology might help someone remember.
Okay, whatever works. That captures the core pathological process mentioned in the notes, yeah?
Okay, so moving on. What about risk factors?
Well, interestingly, the notes state pretty clearly there are no well-defined risk factors for MSA.
Ah, okay. That's actually quite important to know. So you shouldn't be looking for specific lifestyle links or anything like that as strong causes.
Exactly. What we do know, based on the notes, is the typical demographic. It usually affects adults, most commonly hitting between 50 and 60 years old.
50 to 60, and any gender difference.
The notes say it's slightly more common in men than women.
Okay, so while the why isn't clear regarding specific risks, knowing the typical age and that slight male predominance helps picture who might be affected.
Precisely. And this links directly into the pathophysiology, how the disease actually unfolds in the body.
Right, the mechanism.
The fundamental process is that progressive degeneration and loss of nerve cells.
Okay.
And this specifically targets certain brain regions. basal ganglia, the cerebellum, and areas of the autonomic nervous system.
Which, as you said, lines up perfectly with the main symptoms, right? Basal ganglia damage causes the Parkinsonism.
Correct.
Cerebellar damage causes the ataxia.
Yep.
And autonomic system damage causes all those autonomic problems.
You got it. So the pathophysiology is essentially the physical damage, the breakdown of nerve cells in those specific locations.
Driven, at least in part, by those alpha-synuclein aggregates, the GCIs we talked about.
Exactly. The how is the nerve loss, whereas basal ganglia, cerebellum, autonomic system, and the underlying what seems to be this alpha-synuclein GCI pathology. Though the Knights do say the mechanisms aren't fully understood.
Still pieces missing. Okay. How common is it? Let's look at epidemiology.
Right. The notes confirm MSA is rare, particularly in the UK. The exact prevalence is a bit uncertain.
But definitely less common than Parkinson's disease.
Oh, yes. Explicitly stated it's less common than Parkinson's. That's
Yeah.
a really key comparison point, especially when we get to diagnosis.
Good point. It affects both men and women, typically in that 50-60 age bracket we mentioned.
That's the typical range, yes. Worldwide, the incidence figure quoted is about 0.6 cases per 100,000 people per year.
0.6 per 100,000, so pretty rare.
And that rate increases with age. While some reports on gender differences vary, the notes stick with it being slightly more common in men overall.
And onset age.
Most people develop it after age 40, but the average age of onset is around 55.
Okay. So, if you're revising, what do these numbers really tell you? They say MSA is uncommon, it mainly hits people in middle to older age, and it's not the most frequent cause of Parkinsonism you'll encounter. Parkinson's disease is much more common.
Knowing those basic stats definitely helps put it in perspective. Now, shall we move on to a really high-yield section for revision? Differential diagnosis.
Ah, yes, this sounds crucial. The notes stress that telling MSA apart from other conditions is challenging.
It really is, because those early symptoms, the Parkinsonism or the ataxia, can look like other, sometimes more common, disorders.
So what are the main mimics we need to think about?
According to the notes, the big ones to differentiate from are Parkinson's disease itself, progressive supranuclear palsy, PSP, and corticobasal degeneration.
CBD.
Okay, PD, PSP, CBD. And they also list things like pure autonomic failure, maybe even multiple sclerosis in some cases.
Right. So how do you start suspecting MSA when it could be, say, Parkinson's? This is where the details are vital, isn't it?
Absolutely. The notes list specific features that should make you think MSA rather than Parkinson's.
Okay, let's hear them.
These include really rapid symptom progression.
Faster than typical Parkinson's.
Much faster. Often. A poor response to levodopa therapy. That's the main Parkinson's drug.
That's a huge one. Levodopa usually works well in PD, at least initially.
Exactly. Also, very pronounced autonomic features like severe drops in blood pressure on standing or significant bladder problems appearing relatively early in the disease course.
Early and severe autonomic issues. Got it.
Then, disproportionate rigidity and slowness of movement, bradykinesia, compared to the amount of tremor. Severe speech impairment is common. And characteristic respiratory issues, like problems swallowing leading to aspiration, or odd breathing patterns like inspiratory gasps or stridor.
Wow, okay. That list is gold dust for revision. That poor levodopa response, combined with early, severe autonomic failure, those seem like massive red flags for MSA over Parkinson's.
They really are. So if you have a patient who looks Parkinsonian but isn't getting much benefit from levodopa, and they're having major dizzy spells when standing up, or bad bladder issues early on.
You have to think MSA high up on your differential list.
Precisely.
Maybe a way to remember those key differences from Parkinson's. How about MSA-RAPS down on levodopa and auto? For rapid progression, autonomic, pronounced dearly, poor levodopa response, severe speech stridor.
I like it. MSA-RAPS down. That captures those key differentiating points nicely.
Okay, good. Let's dig into the clinical presentation in a bit more detail than maybe breaking it down by those two subtypes, MSA-P and MSA-C.
Sounds good. Let's start with MSA-P, the Parkinsonian subtype.
Right, P for Parkinsonian. So the dominant features here are motor symptoms resembling Parkinson's.
Yes, primarily the slowed movements, bradykinesia, plus rigidity or stiffness, and postural instability, which means balance problems often leading to falls.
Okay, classic Parkinsonism. But it's not just that in MSA-P, is it?
No, absolutely not. Critically, MSA-P also features significant autonomic disturbance. The notes specifically call out erectile dysfunction often being an early symptom.
Early ED, right.
And severe postural hypotension, that big drop in blood pressure when standing up, causing dizziness or even fainting. Plus an atonic bladder, meaning the bladder doesn't empty properly. And constipation is common too.
So Parkinsonism plus a whole suite of autonomic problems. Anything else for MSA-P?
The notes also list other potential issues, maybe some mild cognitive changes or intellectual impairment, especially in older patients. Depression can occur, sleep problems like insomnia, daytime sleepiness, restless legs, and sometimes even hallucinations or dementia, though maybe less typically than in some other conditions.
Okay, quite a mix. Now, what about MSA-CC for cerebellar?
Right. So this subtype primarily presents with cerebellar ataxia. The main issue is with the cerebellum, the part of the brain coordinating movement.
So what does that look like symptom-wise?
Symptoms of cerebellar ataxia include problems with gait and balance. So, an unsteady, uncoordinated walk, difficulty with coordinating movements, like reaching for things smoothly, and slurred or disrupted speech, which we call ataxic dysarthria.
Makes sense. Coordination problems affecting walking, limbs, and speech. And the autonomic side?
Ah, yes. Importantly, the notes state that MSA-C shares many of the same significant autonomic disturbance features seen in MSA-P.
No, okay. So the autonomic dysfunction is prominent in both subtypes.
Yes. Orthostatic hypotension, urinary and bowel dysfunction, like incontinence or constipation, sexual dysfunction, these are common in MSA-C too.
Right. So, quick summary for revision. MSA-P is Parkinsonism PLUS autonomic problems. MSA-C is cerebellar ataxia PLUS autonomic problems.
That's the core structure.
And a key point across both, according to the notes, is that those autonomic symptoms often appear before the main motor symptoms kick in.
That's often the case, yes. And reinforcing that differential point, again, a poor response to levodopa for the Parkinsonian symptoms is common across both subtypes where Parkinsonism is present. Corticospinal tract signs seem less prominent generally.
Okay, crystal clear. Now, how do we actually go about diagnosing this? It sounds like it relies heavily on the clinical picture.
It does. The notes explain diagnosis relies on combining those clinical features we've discussed, neuroimaging findings, and crucially, ruling out other conditions.
And there are different levels of certainty.
Yes, they outline diagnostic categories, definitive MSA, which usually requires post-mortem confirmation.
Right, seeing the actual pathology.
Exactly. And then clinically, during life, you have probable and possible MSA.
Okay. What makes a diagnosis probable?
The notes detail major features supporting a probable MSA diagnosis. These fall into three domains. First, severe autonomic dysfunction. Think orthostatic hypotension, urinary issues, erectile dysfunction.
The autonomic hits.
Second, extrapyramidal tract signs, basically Parkinsonism like bradykinesia, rigidity, postural instability, and importantly, the tremor, if present, is usually not the typical pill-rolling wrist tremor you see in classic Parkinson's.
Different type of tremor or less prominent tremor, maybe?
Often, yes. And third, cerebellar function signs like gait or limb unsteadiness, ataxia, that's slurred speech, ataxic dysarthria, or problems with eye movements.
So you need features from those three areas, autonomic, extrapyramidal Parkinsonian, and cerebellar, for a probable diagnosis.
Generally reflecting that multi-system involvement, yes. For a possible MSA diagnosis, the notes say you need either Parkinsonism or cerebellar signs, combined with at least one feature of autonomic dysfunction.
Okay, that aligns with the PNC subtypes having both motor and autonomic features.
Exactly.
And what investigations help support the diagnosis or rule other things out?
There's a whole range listed. Structural brain imaging like MRI is important. Functional imaging like PE scans. Specific cardiac sympathetic imaging. Cardiovascular autonomic testing to objectively measure things like blood pressure changes.
Right, quantify that autonomic failure.
Exactly. Olfactory testing, sense of smell testing, sleep studies looking for things like REM, sleep behavior disorder or stridor, urological evaluations for bladder issues, and assessments for swallowing, dysphagia, and cognitive function. It's a pretty comprehensive workup.
Feels like you're testing all the systems that can be affected. Any specific tests that are really key for differentiating from Parkinson's?
Yes, the notes highlight a couple. Autonomic function testing is crucial generally for assessing bladder function and other autonomic abnormalities objectively.
Okay.
But for distinguishing MSA from Parkinson's specifically, the notes really emphasize iodine-123 MIBG scintigraphy.
The MIBG scan, how does that help?
It looks at the nerve supply to the heart, the cardiac sympathetic nerves. The key finding mentioned is that uptake of the tracer is typically preserved or normal in MSA, but it's significantly reduced in Parkinson's disease.
So a normal MG scan in someone with Parkinsonism and autonomic failure would point towards MSA and away from PD.
That's the differentiating point highlighted. Yes, it's a really valuable tool in that context.
That's a definite must-know for revision then, the I-123 MIBG scan.
Absolutely. Also mentioned are MRI and proton magnetic resonance imaging. These can show patterns of brain degeneration, atrophy in specific areas like the putamen, pons, or cerebellum, and sometimes characteristic signal changes on T2-weighted scans, like the hot cross bun sign in the pons, although that's not always present or specific.
Okay, imaging can show the structural damage.
And another functional test mentioned for differentiation is fluoride 2 F18 FDG-PT imaging. This looks at brain metabolism and can apparently help differentiate from Parkinson's based on activity levels in the caudate and putamen parts of the basal ganglia.
So more detailed brain activity patterns.
Essentially, yes. And while definitive diagnosis, as we said, often needs histology post-mortem to see those GCIs.
The glial cytoplasmic inclusions.
Right. These various tests, the clinical exam, autonomic testing, MABG scan, MRI, PT, all help build the clinical picture during life and exclude other possibilities.
So for investigations, maybe group them in your mind. Brain imaging, MRI, PET, autonomic tests, function tests, MEG, and then the functional assessments, swallowing, sleep, etc. And really nail down how MIBG and maybe PET findings help separate MSA from PD.
That's a very good way to structure it for recall.
Okay. Now, the tough part, perhaps, management. The notes state up front, there's currently no cure for MSA, right?
That's the crucial and sobering point. There is no cure.
So the focus has to be elsewhere.
Entirely on symptomatic treatment and supporting the patient, trying to improve or maintain their quality of life for as long as possible.
And that requires a team effort.
Absolutely. The notes explicitly state a multidisciplinary team approach is necessary. This involves medications, physical therapy, occupational therapy, speech therapy, psychological support, regular monitoring, and actively managing any complications that arise.
Okay. And the notes emphasize that no available therapy actually reverses or even halts the progression of the disease.
Correct. Management is purely about tackling the symptoms, mainly the Parkinsonism and the autonomic failure. Though the notes do add that treating the extrapyramidal, Parkinsonian, and cerebellar symptoms can often be quite challenging.
Right, because the standard treatments might not work as well as in other conditions.
Precisely. So specific areas of management listed include things like managing the postural hypotension, using non-drug methods first, then medications if needed, treating constipation, managing urinary incontinence, which often progresses to needing catheterization.
Practical supportive measures.
Very much so. Strategies for fall prevention are key, given the postural instability and ataxia. Encouraging physical activity is important to prevent deconditioning. The notes specifically mention water-based activity as being potentially helpful because it supports the body.
Oh, interesting. Aquatic therapy.
Yes. And of course, speech and swallowing therapy are vital, especially to try and prevent aspiration pneumonia.
What about medications for the movement symptoms?
Levodopa and dopaminergic agonists, the standard Parkinson's drugs, are often tried. But, as we've stressed, the response is frequently poor or unsustained in MSA. Still, a trial is usually warranted.
Worth a try, but don't expect miracles like in PD.
That's the reality. Other agents mentioned include things like recombinant erythropoietin, which might help with functional capacity or anemia, if present, and some less commonly used drugs are listed like NSAIDs, antihistamines, or statin analogs, perhaps for specific symptoms but not mainstays.
Any hope on the horizon? Future options?
The notes briefly touch on future therapeutic options. They state, no neuroprotective treatment exists, yet nothing proven to slow the disease down. But potential candidates are being considered or are in early trials looking at things like growth hormone, certain antibiotics like minocycline or rifampicin for the potential effects on protein aggregation, or drugs like rasagiline, but nothing concrete yet.
So the management philosophy is really about comprehensive support, symptom control where possible, maximizing comfort and function, and anticipating problems, all while acknowledging we can't yet stop the disease itself.
That sums it up well. It's about providing the best possible supportive care.
Which leads us logically to prognosis. How does the outlook generally look according to the notes?
Unsurprisingly, given everything we've said, the notes state the prognosis is generally poor. It's characterized by progressive neurological decline.
And how fast does it progress?
The rate of progression does vary quite a bit from person to person, but the notes give an average life expectancy after diagnosis of typically 7 to 10 years.
7 to 10 years. That's a quite rapid progression.
It is, sadly. Though again, there's individual variation around that average.
Are there factors that suggest a worse or faster prognosis?
Yes, the notes list factors associated with shorter survival time. These include being older at the time symptoms start, needing bladder catheterization relatively early in the disease course.
That early autonomic failure marker again.
Exactly. And having early, widespread, or generalized autonomic failure.
Okay, so older onset, early catheterization needs, early severe autonomic failure point towards a faster decline.
That's what the evidence suggests, according to these notes.
And how do patients typically pass away? What are the terminal events?
The common terminal events mentioned are bronchial pneumonia, often resulting from aspiration due to swallowing difficulties.
A major complication we'll touch on.
Yes. And sudden death, which can sometimes occur, possibly linked to the severe autonomic dysfunction affecting breathing control or heart rhythm during sleep.
Right. So this section really paints a picture of the typical disease course, the duration, and highlights some markers that might predict a more rapid progression, important for counseling and planning care.
Definitely vital information.
And finally, the notes wrap up with complications. These really flow from everything we've discussed, don't they?
They do. They're the direct result of the disease progressing. The main complications listed leads to falls and related injuries.
Right, from the Parkinsonism, ataxia, and maybe the postural hypotension.
Exactly. Respiratory issues are prominent, specifically aspiration pneumonia, because swallowing becomes so difficult for many patients.
A major cause of morbidity and mortality.
Indeed. Cardiovascular problems can also arise, stemming directly from that severe autonomic dysfunction, things like very unstable blood pressure or potentially arrhythmias.
And the overall impact.
Ultimately, all these complications contribute significantly to a reduced quality of life. The notes conclude this section by circling back to management, reiterating that it involves supportive care, symptom management, and those multidisciplinary interventions aimed specifically at trying to prevent or address these complications as they arise.
Okay. So we've really journeyed through this whole set of revision notes on MSA now.
We have covered the definition, the underlying pathology with α-synuclein and GCIs, who typically gets it, how it damages the brain, those crucial points on differentiating it from conditions like Parkinson's.
Especially the poor levodopa response, the severe early autonomic features, and that key I-123 MIBG scan finding.
Right. We've looked at the clinical features of the P and C subtypes, the investigations used, the current management strategies focusing on symptoms and support.
The generally poor prognosis and the common complications like falls and aspiration pneumonia.
We've tried to pull out those key nuggets for you. The three core symptom areas, the pathology, the PD differentiators, the subtypes, the lack of cure, but focus on multidisciplinary care.
Hopefully making this complex topic a bit more digestible and high yield for your revision.
So maybe a final thought to leave you with, based on all this.
Mm-hmm.
Given the real challenges in diagnosing MSA early and the fact we don't have treatments to stop it yet, what do you think is the single most crucial aspect of managing a patient with suspected MSA right from day one?
That's a good one. Is it nailing the diagnosis as quickly and accurately as possible, or is it maybe initiating that comprehensive, supportive, multidisciplinary care immediately, even while the diagnostic picture is still forming?
Something to ponder. It really connects the dots between the investigations, the management philosophy, and the prognosis, doesn't it?
It really does. That's definitely food for thought. And if you are looking for more resources to help nail your revision on tricky topics like MSA, do check out PassTheMSRA.com and FreeMSRA.com.
Thank you for joining us for this deep dive into multiple system atrophy.